As a facilitator, DermaPen with 1,920 puncture channels per second now works to serve as part of combination therapies for treatment of alopecia. By itself, DermaPen is not going to deliver the results that your patient will expect. So this becomes part of a combination therapy, particularly with appropriate PRP or appropriate combination therapies that could be nanofat, but also appropriate mesotherapy as well. A filament comprised of keratin that is designed to keep us warm. So with this, we've got the hair bulb, which is then connected to vascular activity within the hypodermis, which then sends nutrients, hormones, and growth factors, now enabling nutrients to be delivered to the bulb, which now enables the hair to physically grow itself. We've got two different types of hair that we're going to see on the body. Vellus hair is the blonder, lighter hair that's thinner, and we find that everywhere over the body, even when you can't see it. Terminal hair is where the hair is darker, longer, and thicker. So if you think of pubic hair, the hair on your legs, if you think of axillary hair or underarm hair, these are all examples of terminal hair growth. Just purely for definitions, the hair on your head is most commonly called capillary or capillary hair for ease. The hair growth undergoes three types of stages, and depending on the type of alopecia which the patient has, this is going to influence your style of treatment, but this is also going to influence what your visual cues and endpoints are. So anagen is where you physically got the hair growth phase. You've got your preparation phase with catagen, and then with your telogen, it's resting and then shedding. So with this, we often find that if the hair is coming out during telogen phase, you may see that there is a little root, there is a little bulb at the base of that. So based on what you see will determine, in some cases, the type of hair loss that we see. Not all forms of alopecia are suitable for DermaPen treatment. So we want to be very, very clear as to who is going to be successful, who is an optimal candidate by comparison to who is not going to be a good candidate or who will experience no success at all. You'll be very surprised, particularly as we go through these categories, as to how many patients experience some way, shape, or form of alopecia. The first area I want to have a look at is tractional alopecia, and this is our example here. Tractional alopecia is where there is pulling and pressure on the hair, which then creates pulling and pressure on the hair and its growth in the bulb, which then eventuates in snapping of the hair. Areas of consideration. This can come through most commonly hairstyles. So if the hair is braided, if the hair is weaved, if there is hair extensions glued through, if there is a high ponytail, if there is a tight bun, but also if there is headwear that is worn. So if we consider someone in the construction industry where there is tractional alopecia around the temples, where a helmet or a bike helmet rubs against the area here. But if we also take into account certain headwear or religious headwear where clips and where tightening and braiding of the hair creates pressure and eventual snapping. If this occurs over a long period of time, the pressure and the snapping is now going to contribute to an abnormality within the hair follicle. An abnormality within the hair follicle is going to be abnormal collagen deposition, and it creates scar tissue. This leads on to what's referred to as cicatricial alopecia. So tractional alopecia is possible to treat, but if that has occurred over such a long period of time that now the hair follicle is replaced by scar tissue, cicatricial alopecia is going to be substantially harder to treat. So we depend on how far into severity to determine whether the patient is going to be able to experience success or not for this. We then move into androgenetic alopecia or male pattern baldness, which can also be a female pattern baldness as well. In order for your treatment to work, there needs to be a follicle that is active and is not dormant. I was struggling to think of Norwegian celebrities, and I'm not very good at this. So I'm going to talk about the British royal family. So if Prince William comes to visit you, it's not going to happen. But if Prince Harry comes to visit you, we've got a few more weeks left, and then it's going to be too late. So with this, if it's dormant, you've got absolutely no opportunity for this. In the case of androgenetic alopecia, what we have is an imbalance of 5-alpha reductase, which is a balancing enzyme, which then enables control between our steroid and anabolic steroid hormones, and relationship between the adrenals and relationship between the testicles, but adrenals and then ovaries for female. So we can often find that there can be forms of androgenetic alopecia, which can be part of conditions such as polycystic ovarian syndrome. Otherwise, we can go into the other direction, which can create hirsutism, which is increased hair growth anywhere on the body. Alopecia areata here is where there is an autoimmune condition, and the autoimmune condition now views the hair, the follicle, and the bulb as being a pathogen. So as such, similarly to vitiligo as a skin condition where the melanocyte is viewed as a pathogen and the body starts destroying the melanocytes, in this case for alopecia areata, the body starts destroying the follicle and starts destroying the bulb, which means hair growth can't sustain. This is an autoimmune disorder. So as such, you can only treat if there is stability. So in most cases, there is normally some steroid combination therapy to enable an immunosuppressant response out of this. Tractional, cicatricial, androgenetic, and alopecia areata only affect capillary hair or the hair on your head. Telogen effluvium is where there is thinning of the follicle. If there's thinning of the follicle, that means it is not able to sustain a thicker hair growth. This can come through from certain medication. This can come through from elements such as pregnancy. It can also come through from major dietary changes. So if we look at bulimia nervosa, anorexia nervosa, patients will begin losing and thinning hair on their head, which is a form of telogen effluvium, but patients will begin an increase of hair growth of vellus hair on their body. So we need to find what the physical trigger or activator as to why the hair is becoming thinner. In many cases, we're going to require a drug combination therapy, which will be a follicular maximizer. So I will refer to, at a few points, a drug called minoxidil. And minoxidil is a drug which will keep the follicle in a maximized position. Although this is going to be successful for things like early stages of androgenetic alopecia, for telogen effluvium, it's not suitable for all types of alopecia. Final area for consideration is totalis. Totalis is where there is complete removal and loss of hair on the head. This is argued to be autoimmune. There is absolutely no solution for this. And the final one is universalis, where there is not one hair on the body. So that means no hair on the head, no eyebrows, no eyelashes, no axillary hair, no pubic hair, no leg hair. The only example I can think of for universalis, if you're familiar with a British television show called Little Britain, there's an English comedian called Matt Lucas. There is not any hair on him. And so when the patient is experiencing totalis or universalis, there is nothing in aesthetics that we can do that is going to get the hair to grow. Having a look at triggers and activators, typically if there is an anagen hair loss or a hair shaft abnormality, so looking at tractional alopecia, cicatricial alopecia, you'll normally notice that there is no root on the end of the hair. So that is a sign that the hair has undergone some form of snapping. In regards to male pattern baldness or hair loss in this, what we notice is that the issue is more than just tension or pressure on the hair. What we have is a sensitivity and an imbalance of 5-alpha reductase within the system. This in turn now creates a reactivity which now sees terminal hair move back into vellus hair until eventually the follicle becomes dormant and it's unable to grow hair. So typically we see this at the back of the crown, so this section here, but we can also see this for both males and females at the very front. We call this witch's peak in English, through this section here. So if you imagine someone such as Jude Law, the actor, through this section here, but if you imagine someone such as Bruce Willis, the actor, it's through the back section here as well. Once we get into telogen hair loss, it's not uncommon that patients will see a physical root on the end of the hair. So this is a sign that the body has physically shed the hair, and the follicle is now trying to remove any remnants of the hair within that. So that could be based on certain medications, contraceptive pill, anticonvulsants, there can be some form of antidepressant tablets. If there's major rapid weight loss, but also if the body is under immense periods of stress, we can begin to see this style of hair loss, but also hair thinning as well. One example for this is, if you may recall, for those of you old enough, in the late 1980s and in the early 1990s, Princess Caroline of Monaco, who then underwent major telogen effluvium and then hair loss as a result of medicational life that's argued to be for her. DermaPen itself is a facilitator for your treatments. So there is no patient where you will be able to use DermaPen and you will be able to create a restoration of hair. So it must become part of a combination therapy. Its effects, firstly, particularly for something like the early stages of cicatricial alopecia, or particularly if there is vascular imbalance, which means that capillaries cannot deliver growth factors, hormones, and nutrients, is angiogenesis, but also being able to mechanically break down the existing scar tissue. The angiogenesis comes through platelet-derived and vascular endothelial growth factors, which now serves to strengthen the capillary network and now serve to now increase the nutrients, oxygen, growth factors, and hormones to now sustain positioning of the follicle and also the bulb within the follicle itself. As part of combination therapies, if you've got nearly 2,000 puncture channels per second, this is now going to give you not just the benefit of collagen regulation, if there's scar tissue, of angiogenesis and stimulation, but with nearly 2,000 puncture channels per second, just like your mesotherapy with your MG collection, we can now infuse appropriate mesotherapy or appropriate PRP or even nanofat in some cases, which is rich in stem cells, to now promote more effective hair growth. So long as you target the physical trigger and activator, your results can be longer lasting. But there may be some drug combination therapies, particularly for alopecia areata, and particularly for androgenetic alopecia or some cases of telogen effluvium, which the patient is going to absolutely need to fully commit to. As we've seen earlier on today, the difference from technique that if you inject for our traditional hair loss procedures using mesotherapy needle, it will deliver an active solution into the skin. But even with a mesotherapy gun, which may be delivering 5 needles per second, 5 needles every 3 seconds, by comparison to DermaPen with 1,920 puncture channels per second, you're going to create a far more advantageous infusion and distribution of an active substance within the skin. So this means that DermaPen is the most efficient way to deliver your combination therapy into the skin, but DermaPen now also serves as the most comfortable way and fastest, quickest combination therapy for now aiding distribution and activation. PRP is going to increase your growth factor concentration by around about 3 to 5-fold. A standard DermaPen procedure will take it up to around about 3-fold. So as such, an increase of growth factor potential is going to hopefully aid a potential of more effective hair growth. With this, it's not guaranteed. If the patient is of bad quality health, bad quality platelets, you're not going to achieve phenomenal results. With appropriate mesotherapy that is specifically designed and scientifically backed up for hair growth and for hair restoration, again, this is going to be an option for those of you who can't work in with PRP to now serve as part of your combination therapies. There are some innovations coming through where we're seeing developments for botulinum toxin, and this is developed particularly for the Italian market, where highly diluted botulinum toxin is being able to show a balance of angiogenesis and also being able to subsequently enable more effective nutrients to be delivered to the follicle and subsequently to the bulb. We also see developments with mesotox or botulinum toxin for rosacea, and are also seeing innovations for hyperhidrosis or excess sweating. Other areas of consideration include minoxidil solution. Minoxidil solution initially was designed for blood pressure, and then what they discovered was from the systemic medication to turn it into a topical medication, it serves as a follicular maximizer. So I want you to think of planting at this point. So if you have a large pot plant and you put a big tree in it, then that large pot plant is going to be able to survive that larger tree. However, if you then try to put a big tree into a tiny, tiny little pot, it's not going to be able to grow. The pot is going to restrict it with this. So it becomes like a bonsai plant. So what the minoxidil does is now maximizes the follicle. Small follicle, small thin hair. Large follicle, thicker hair growth with this. So as such, use of minoxidil, which is anywhere from 2.5 milligrams up into 5, and it can be up to 10, which would probably be on prescription here, needs to be used once to twice a day as a follicular maximizer. Stop using it, you go back to where you began. So it becomes a lifelong commitment. Again, although it's an over-the-counter medication for 2.5 and 5 milligrams, still seek advice of a medical practitioner or the pharmacist to advise that this is indeed the right medication. The minoxidil is going to be suitable for early stages of androgenetic alopecia. It won't work for late stages, and it can be suitable for telogen effluvium where there is thinning of the follicle. It's not going to work for any other type of alopecia or hair loss. Finasteride is a drug which is going to balance out 5-alpha reductase. The finasteride is a controversial drug, and the reason why is because dosage has changed significantly over the last couple of years. With finasteride, it needs to be prescribed by a medical physician, so they will need to be under their care in order to receive this drug, and they will advise the best dosage for that. However, the challenges for the traditional dosage, which was around about 4 milligrams taken daily, this is only given to males, and it's only for early stages and mid stages of androgenetic alopecia, is erectile dysfunction. Around about 70% of patients on the drug would experience erectile dysfunction, and then those patients who then went off the drug, they were finding anywhere around about 50% of those patients were experiencing long-term erectile dysfunction. The other challenge also with this is particularly the risk of sterility. And so the challenge is for patients who are beginning the early stages of androgenetic alopecia, their early 20s to their mid 20s, they're in baby-making years, potentially. And so there's always been practitioners who've been wary of giving this drug to patients under the age of 35 for risk of sterility, which then causes longer-term challenges, particularly if they're wanting children. So from the traditional 4 milligram dose, which also was showing risks of psychosis and depression and a whole bunch of other consequences, the more up-to-date dosage is to reduce it down to about 1 milligram taken a day. But again, the medical practitioner, the physician, will need to advise the best course of treatment. One of the more simple ways to promote vascularization and to promote more effective angiogenesis is to see the patient regularly for LED or low light intensity light therapy, otherwise known as cold laser. And this can serve as a combination therapy in between your DermaPen procedures to now enhance and to maintain your results. we're going to see that particularly with PRP, you can shorten your treatment intervals to almost every 4 weeks. So because you have an increase of, shall we say, your good growth factors, this is going to override the risk of your profibrotic or scar growth factors, which means with PRP or nanofat procedures, you can treat with pinpoint blood, with moderate blood, as often as every 4 weeks. But otherwise, depending on the mesotherapy that you are using, then follow the directions of the manufacturer to make sure that that is being used appropriately. There's a couple of techniques that you can use to administer. It's not uncommon for many modern patients to have a needle psychology. And needle psychology is as simple as I've not undergone a medical procedure or my money has not been well spent in a medical clinic unless a needle has physically gone into me. So with these types of patients, I've already proven and shown you on the biopsies that a DermaPen will distribute an active substance more effectively, more comfortably, and with greater saturation than what a single injection will. But you're going to have some patients who feel that this still needs to be an integral part of their physical procedure. If that's the case, you can do some localized mesotherapy injections on the areas of concern or any areas to keep the patient satisfied and happy. But otherwise, infusion technique with your DermaPen is the most effective way with 2,000 puncture channels per second to now administer your procedural active, whether that's PRP or whether that's traditional mesotherapy. PRP is a really inefficient procedural glide. It's very, very runny, which means that it's hard to distribute, particularly the more hair loss that there is. And likewise, it means that it's going to create a very uncomfortable treatment, so it doesn't glide or lubricate. This is also going to be the case with many water-based mesotherapies. So what my suggestion is you have the choice of either the original Hyalactive, or you can use the MGHA 35 or the 35 plus. Apply this onto the scalp first, and this will enable a smooth lubrication. So physically, the DermaPen can glide through the area without dragging, without pulling, without discomfort. You only need around about 2 to 4 pumps of the Hyalactive. You're only going to need about 2 milliliters of the HA35 or the HA35 plus. Apply that over the scalp, and then in a closed airtight syringe with your PRP, or alternatively with your mesotherapy, you're going to need 2 hands for this technique. I like to use a 23 gauge 40 millimeter needle. It's huge. It's not being injected. The reason why I use this is because it squirts and distributes the product, so it remains on the scalp as opposed to ending up on the wall or the floor in that case. So with this, all you simply need to do is just place it onto the hairline, squirt, then catch it with the DermaPen, and then start distributing it through with the DermaPen. For your DermaPen procedure, what you want to do is use small vertical inflections. So for the treatment, how this is going to look is going to be a short movement. So traditionally, when you perform on the face, you're going to use the star technique, which is a vertical, horizontal, diagonal 1, diagonal 2. However, if the patient has a relative amount of hair, trying to get that type of technique is going to be incredibly difficult to work through the hair without discomfort. Likewise, also, I often hear rumors that microneedling is inefficient because you're going to risk pulling the hair out. In that case, that's referring to the old-fashioned rollers. So if you have an old-fashioned roller at 1 millimeter, 1.5 millimeters, as the needles penetrate at a 90-degree angle, that's fine. But as some 75% of the revolution cuts and arcs through the skin, you're going to risk the hair being pulled out. So the advantage of DermaPen is that it's a vertical entry point and vertical exit point. So if you follow a technique of bzz, 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 short inflections using a vertical technique, you're going to find a very, very comfortable administration. If you try doing long strokes and the patient has hair, you're going to find that it gets stuck and it's going to be uncomfortable. So for this style of technique, you want at full speed, speed 4, 120 revolutions per second. Apply your product, and then small vertical inflections. Apply more product, catch it. So particularly if the patient has moderate hair, you're going to find vertical, horizontal, diagonal 1, diagonal 2 very difficult. So just work in small vertical movements right around the scalp on the areas of particular hair loss. So the DermaPen now serves to facilitate an ease of administration, an ease to move this through, but also to now promote administration of your PRP, but also of your mesotherapy as well. You need to see for mild alopecia at least pinpoint blood, but for more severe cases, because the nutrients which are now delivering for the follicular bulb are in the hypodermis, you're going to need to see some moderate blood come through. My definition of moderate blood, you're going to be looking at this type of effect here. That's a good endpoint there. So nothing more severe, nothing less in most cases. So for this procedure, once you've finished, you can massage in any remaining solution, or you can finish off with a very light spritz, only for androgenetic or telogen effluvium of minoxidil solution. With this, I don't recommend that you microneedle in minoxidil solution because it initially was designed for blood pressure. If you've got too much solution going in, there's always the risk of the patient fainting or passing out on you. So use this as a finishing product, but don't physically use this as your gliding product. In the land of mesotherapy, there are options where they've created safer versions of minoxidil. You're also going to find that there's other types of dutasteride, finasteride. There's lots of options out there for reputable mesotherapy, and including the anesthetics range with hair loss control as well, which will give you some good options to combine in physically with your DermaPen. You want to treat as often as every 4 weeks. Having a look at some before and after pictures. Both these patients are from the south of Egypt. This is tractional alopecia from wearing of a hijab. So you can actually see the position of where the clips sit. My recommendation for any type of hairstyle, any type of headwear, any type of extensions or additives for this is to change your position. So if the clips are sitting in the one place and it's rubbing on the one area, change position of the clips very, very slightly so there's alternation. For hair extensions, for weaves, for anything that's sewn through for this, try and change the area very, very slightly so it's not the same area of hair that's getting the same level of pressure. For hairstyles such as tight braids, for buns, for ponytails, again, change position, change angle, just to create a little bit of a break. The first one is 3 treatments, the second one is 2, both are with PRP as part of the combination therapy. This is telogen effluvium, and so we see hair thinning here. When we look at these types of pictures, it's not uncommon for practitioners to go, I can see a difference, but it's not Rapunzel, it's not phenomenal. Bearing in mind that if the patient's got long hair in the first place, you're not suddenly going to have hair this long in the space of 2, 3, 4 procedures. So the hair still physically needs to grow in order to create greater density. But both 4 treatments, Hyla Active as the treatment base and PRP combination therapy. For telogen effluvium, again for hair thinning, we also see that the patient has grown their hair as well. And this is 3 procedures, PRP combination therapy. Telogen effluvium can be successful and respond particularly with minoxidil. For females, it might be 2.5% to 5%. So in order to facilitate combination therapies, the patient may have steroid injections, so a triamcinolone acetonide or a prednisolone injections. These are only administered by a medical physician in this case. What you'll notice is that the patches of the hair can change very regularly. In some cases, patients may find that it's as frequent as every week. So hair grows and then it falls out on this section, and then hair begins to grow in a patch in another section. And then that changes again in the next week or the next few weeks. So I want to show here that we can see, even after just one procedure, how we've now facilitated vellus hair growth, and then eventually the vellus hair growth will then hopefully move into terminal hair growth as part of combination therapies. This is just one treatment. However, for this female in her teen years here, following 8 treatments, you can see from the start, treatment 4, and then after 8 treatments, how the combination therapy, but in some cases, they may require steroid combination therapies, can enable some stability. For alopecia areata, you would expect results so long as there's been at least 6 months stability for the condition prior. If it's showing signs of changing of movement, the odds of longevity are not going to be particularly positive in this case. I've actually finished early for the first time ever in my life.